or a conference. So thank you once again. Without wasting time, we would move on to the panel. A lot of the questions that I had raised initially in the panel have been answered in the last session when we were discussing all our queries with the expert panel that we had set forth. But I would still like to know from individual experiences from all of you all who we have gathered as experts from our country and from the other Asian countries as to what their practices reflect and how they manage patients in their setting. So I don't have any disclosures, but I apologize for heavy use of names. Thank you. So this is the flow of the panel that we are going to conduct, and we may cut short some things in because we are running short of time. But we already know that metastatic disease is treatable but incurable. However, there are long-term series that show that about 1 to 3% of survivors can be seen at 15 and 20 years after they've been detected of having metastatic breast cancer. Even before the oligometastatic term was coined, there was a large multi-center study of 5,206 patients showing that when you do perform a lung metastasectomy with curative intent, you can have a long-term survival. And the survival ranged from nearly 36% at 5 years to nearly 22% at 15 years. And at that point in time, in 1996, with not very sensitive imaging, not very sensitive tools to perform these kind of surgeries, you almost felt it was magic in metastatic setting. And now that we have improved technology and therapies, we would expect that we would probably conquer the world with this. And then, obviously, the credit of finding oligometastasis goes to Hellman and Noixaborn. There's absolutely no doubt about that. And with that finding in 1995, we've seen that there is increasing number of publications both on in terms of oligometastatic disease and specifically in terms of breast cancer. However, we are still stuck with defining oligometastasis. So what, according to our esteemed panel, is oligometastatic disease in their personal practice? In terms of number of metastases, time at presentation, organs of involvement, number of organs involved, primary sites, and biology. This is a basket of available definitions. Each one is free to choose one from it. And what would they endorse? Is my question. Starting with Dr. David.
Look, the way I think about it, I certainly, when I'm thinking about bone metastases, I'm thinking about 5. And when I'm thinking about liver and lung, I'm heading more towards 3. I also classify by subtype. So when I'm thinking about ER positive or HER2 positive tumours, I'm heading more towards that number of 5 or maybe a little bit more. And when I'm thinking about triple negative breast cancer, I'm probably thinking 1 or 2. So I sort of try and integrate all of those things into my number. And I also, the time from the diagnosis of the primary, so if it's within 3 months or less, I'm less willing to consider classifying as an oligometastasis, but if it was years, I'm certainly more happy to look towards more 5 metastasis. So I look at a number of factors, subtype being probably the most important, and site. So when bone is, I'm more happy to treat more than elsewhere.
That's a very, very interesting answer, because you've really laid out bare the heterogeneity that is there in your own practice, despite a consensus definition. I would like to also hear from Dr. Kishi. What is it that in Japan you would classify or label as oligometastasis in your practice? Dr. Kishi?
Yep.
Could you hear me?
Yes.
So what would you in your practice consider oligometastasis?
Yes, my opinion about the oligometastasis is a little bit different. From the viewpoint of the immunology, we divided to the each for the first thing, each organ has each immune territory. So then 3 organ metastasis means the three organs immunity were destroyed. So then one organ, two organs, three organs, multi-organs is quite different. But for example, brain metastasis is one organ and one site. We can find so many numbers of brain metastasis if we use minute MRI. So how we can classification of the brain metastasis 3, 5, 11, 10. So we can treat 20 or more in brain metastasis. So we have to establish the some detailed criteria about oligometastasis. But I think the term oligo is not correct term.
I think I totally concur with your answer over there, Dr. Kishi, because we are still learning and we still need to understand the number of organ involvement. That means when they say in the ABC definition that I'm going to perhaps even display a little while later, they are not restricting the number of organs, but that just leaves us with the answer of if you have 5 organs and 5 metastases, do you still label this patient as oligometastatic? Dr. Vinita, would you want to weigh in on this? So if you have a patient with one bone, one brain, one liver, one lung, one node,
so I think
localized to these 5 sites and 5 in number, would you still call this patient oligometastatic?
So I think, in this era when we can safely treat local metastasis, number of metastases matter to me more than the number of organs which are affected. So I think number of metastases, matters more than the number of organs. Even if the patient has one lung, one liver, one brain, one bone, it is fine, but the number should not be very high. The other thing which obviously matters is the disease-free interval which these patients have had and the subtype of cancer. Subtype of cancer to see whether the effective systemic therapy is available or not. For example, ERPR positive tumors or HER2 positive tumors would be more easily treated with oligometastatic approach with local therapy rather than triple negative breast cancers.
So while we have excellent tools and very powerful machines, and now, like we've seen in arrest, where number is really not a limit, do you think that this approach is valid, Dr. Geeta, when it comes to surgical services? What do you think? Just because you're limited by the number of sites you operate, it's a lesser of a privilege for a surgeon? Dr. Geeta, you're muted.
Yeah. So I'm not thinking in number of, in the term of the number of sites one can operate. Of course, you're looking at, it has to be a combination. I would rather agree with what Dr. David said in terms of what would constitute an oligometastatic disease. You have to put everything together because this is one patient that you're dealing with, and the response to the various modalities you are employing is what is going to eventually decide how you're going to treat that patient. And it is going to unravel over a period of time. So if there is a primary and there are 2 or 3 sites of metastasis or possibly even more with a favorable subtype, I would actually be thinking in terms of, I would define my intent first, because you have to make that intent very clear at the beginning, because if you don't, then you tend to withdraw at certain points, which may be very crucial to the patient's final outcome. So I would think like Vinita said, of course, the number of metastatic sites is important because you are trying to put in a combination of treatments to give the best outcome. So I would think that is the way I would deal with it, possibly deal with the primary surgically and leave it to my medical oncology and my radiation oncology colleagues to deal with the metastatic sites.
So while I was just displaying this, what I wanted to show over here is that once the original definition was introduced by Hellman and Weizenbaum, we see that the world over several definitions emerged. And it's only after a decade later, or almost 2-3 decades later, we have a definition or consensus which tells us as to what experts think should be the definition of oligometastasis at this point in time. And they all acknowledge that this is not perfect. And we've seen and heard experts acknowledge that these definitions definitely lack any biological component, they lack meaning in several different perspectives, but this is what we go with and this is what we roll with. So what are the current, while we go through the panel, we had also asked a lot of y'all, what are your practice patterns for oligometastasis in a questionnaire? And we are going to discuss that as well. So a lot of you participated wholeheartedly in the questionnaire from India, from Malaysia, Singapore, Nepal, Bangladesh, Pakistan, and Sri Lanka. And we see that we had 243 responses, mostly from academic institutes, who had, where very few of y'all had site-specific practice. But what I was most encouraged about was to see that only about 50% were radiation oncologists, and rest of the 50 were either clinical oncologists, surgeons, or medical oncologists. So we did sort of garner attention from most of the oncology fraternities. In terms of assessment of their caseload, people who had answered, most of them had a moderate practice of between 100 to 500 patients a year, with few having more than 500 cases a year. And most of them saw about 15 to 20 cases a year of oligometastatic diseases. What did they use in terms of definition? As you can see over here in terms of number of metastases, it was in between 3 and 5. As you've already seen that 3 and 5 are popular numbers in literature, and that is what people have leaned towards. In terms of organ involvement, most of them considered bone as a favored site of oligometastasis versus lung, liver, brain, nose, adrenal, bone marrow, and any other site in decreasing order. When it comes to the definition, combining organ with the number, you saw that there was a people lean more towards up to 5 or up to 3 with any site of bone or visceral metastasis. Very few of them considered only bone as a site of oligometastasis in breast cancer. Now, we've over these talks heard evidence for aggressive therapies. Should oligometastatic patient, all of them receive radical intent therapy? Is the question to the panel. There are several randomized controlled trials, not however specific to breast cancers, who have shown, and I'm not at all going to go in detail because of lack of time. These are all the randomized studies that have shown an improvement either in local control, progression-free survival, or for that matter, overall survival. How do you take into consideration all of this, including the results from meta-analysis for safety and efficacy of therapy, and put into your practice? Is this evidence convincing enough? And I would start with Dr. Ashish Bakshi. He's a medical oncologist on the panel.
So, your question is whether one should treat with aggressive intent.
Yes.
Yes, absolutely. I would treat such patients with aggressive intent. And I mean, obviously, as you know, some of these patients can potentially have a very long-term survival and even cure in a fraction of patients. So one should treat definitely with aggressive intent.
So when you encounter a patient like this in your private practice, would you refer this patient to your radiation oncologist or your surgeon?
Yes. Yes. And I mean, I would be more inclined to use an aggressive approach in patients who are a multidisciplinary approach in the group of patients which are ERBR positive and HER2 positive. Triple negative, how much they will benefit, I am a little bit skeptical at this point of time.
I see you raised hand. You would want to weigh in on this?
So I think, Rima, there is no correct answer to this. There is, you cannot say a right or yes or no for this. You have to individually weigh each patient's, all parameters. For example, if I have a triple negative who failed very quickly after completing the treatment versus a patient who's failed after 2 years or after 4 aggressive, the intent will be not for a patient who's very failing quickly, or for that matter, if there is a patient who already had a locally advanced breast cancer to begin with internal memory, lymph nodes, etc., and has failed very quickly, even if it is an oligometastatic situation, then we know that this patient has a higher chance of distant failure and may not benefit a lot with locally aggressive treatment. So I think there is no one correct answer for this.
So, I'll just go back to the definition. So why the controversy about the management and, diverse opinion? I see it primarily because we still do not have a true definition of oligometastatic disease. So you may have an expert committee may reach consensus, but today's consensus will be tomorrow's controversy. So it is very good for defining, definition of OMBC and subcharacterization to decide the eligibility of a trial and stratification. That's how many of the things came, and for reporting it. So that's absolutely fine. But is it really going deep into confidently identifying what the Samuel Hellman's patient in the spectrum of cancer whose low volume or either solitary or few metastases, if we ablate with surgery or radiotherapy, will change the clinical outcome? I think, and that will be different for different cancer types and in different settings, both at de novo and this thing. And it is a very vast thing. So just because we have a consensus definition by an expert committee or a professional body, it is far from truth. And that is a big challenge. I think that should be the major research focus. And once we have that, then the treatment algorithms will come out very much easily. So I think that is the crux of the problem, what I see. Yeah, not just biological parameters, the tempo of the disease, whether systemic therapy will affect or not, is it HER2, is it basal primary? So there are so many factors.
I actually wanted, to be a devil's advocate here and wonder whether, in the light of what we are seeing with, for example, with the new molecules that have come in for metastatic HER2 positive disease. So does it still remain relevant? As a premise, it might. So we think that this is good prognosis disease, and therefore adding treatment for oligometastases is helpful. But on the other hand, is it? So we have looked at this question before these drugs became available. So I do believe that I think, the trials have to keep up with the fact that the molecular, systemic treatments are also changing and improving outcomes for patients.
That's an excellent question, and I would bring this again to the forum once we discuss the other endpoints. Dr. Vani, quickly, if you want to make one short comment.
Yeah, I just want to make a comment that basically we are all lost in the number game. And in the number game is because we've kind of zeroed down on 3, 5, 7, 10, and that is where we are lost. The basic biology and the organ involved is what is probably the most crucial thing, and that is we are getting lost in the numbers.
I totally agree. It's like staging, where 5 centimeter is T2, but 5.1 becomes T3, isn't it? So we really don't know whether 5 centimeters is the right answer for a stage 2 disease. Moving on, what did our participants in the questionnaire think was relevant to treat oligometastasis patients with radical intent? So most of them said yes. An overwhelming majority said that most of them will treat them. That means 54.3%. Yes, a few of them will be treated by 21, and all of them will be treated irrespective of the site and location was set by the rest of them. Here, we also queried people who said that they rarely ever treat or never treat oligometastatic sites with radical intent, and we asked them what were their reservations. So a few of them said that MDT disagreed. There were resource constraints in their particular setup. They lacked expertise in treating these patients with radical intent. These kind of therapies are unaffordable by patients that they see in their practice. Patient refuses these kind of aggressive therapies, probably because of the potential to toxicities. And a minority said that there was lack of evidence. Looking at what are the purposes of recommending definitive therapy. So in your opinion, as a panel, what do you think is the purpose of treating these patients with radical intent? Is it the overall survival benefit, PFS benefit, local control, toxicity, quality of life, patient-reported outcomes, cost of therapy that needs balancing, delay or deferral of systemic therapy, or ability to stay on the same systemic therapy? And here I would like Dr. Seema Gulia to weigh in, because these are important questions that have never been asked in breast cancer. We see a lot of shift in the role of systemic therapy versus SBRT in terms of non-small cell lung cancer, where people are trying, or for that matter, prostate cancer, where people are trying to defer initiation of systemic therapy, while most of the breast cancer patients stay on systemic therapy in these kind of settings.
So the most important factor for deciding a treatment for oligometastatic breast cancer is there is an improvement in overall survival. That is the most robust endpoint for any therapy in question.
So you would consider only overall survival as an endpoint and not
that would be overall survival is the most important endpoint that I would look at, followed by the progression-free survival. Obviously, all these factors which we have listed are important, but you asked me to rate them. So overall survival is the first and the foremost factor, followed by the progression-free survival. And we do have to look at the toxicity, which we are going to add by offering a treatment to a patient.
Dr.
Yes, I think this is very pertinent question, and this is to me, it is the whole package. It is the system, and it is the patient that is the top priority. Sometimes we use SPR to just delay the toxic effects of chemotherapy. Sometimes we do it for abscopal effect, and sometimes we do it because we want to improve the survival of the patient. So far, all the phase 2 or phase 1 studies have shown local control improvement, and few of them have translated into overall survival. Obviously, with new studies that are showing PROMs and quality of life issues, we are also trying to reduce the toxicity. But to me, it is the combination of these things, and it's a whole package that is important, especially with the advent of new targeted therapies. The combination of SPRT and targeted therapies is also very exciting in the new era. Thank you.
Right. So I think it's an important consideration that we must look at as to what our endpoints are. And it's also important to note that our medical oncologists also agree that overall survival is an important endpoint and not just progression-free survival. And that was pun intended. So once we've established what our purpose is, are we convinced that our overall survival is impacted, for that matter, with the kind of local regional therapy we deliver? And for that, I would like to bring in Dr. Geeta. Is Dr. Shalaka with us?
Yes, I'm with you, Rima, outside.
Shalaka, so maybe you can take that. Are you convinced that overall survival improvement is seen in our patients when we treat with these kind of approaches?
No, I'm not convinced that we have an overall survival benefit. I think here a benefit in progression-free survival would also be good enough. And I'm not sure if we really look for any overall survival benefit of our practice. I mean, if you look at even aromatase inhibitors in adjuvant treatment, I'm not sure if we have a great overall survival benefit, but we have a DFS benefit over tamoxifen, and we have changed our guidelines for that sake. So I think a PFS benefit may be adequate for me to consider. Of course, it's ideal to have an OS benefit, but a PFS benefit is good enough.
Coming to a very important question which has been harped upon during all the previous sessions is the biomarker. The lack of biomarker is palpable. Here you can see that despite whatever selection criteria we have, we are still not able to completely eliminate the disease, and that has been seen in all typical survival curves across all the different oligometastatic settings. And you could see this even through all the Asian data presentation, that these are how the survival curves look. So how can we improve the outcomes? We've heard the experts speak, but I would like to know from the panel also. What are the biomarkers that we are looking at, Dr. David?
Well, I think if you look at the NRG BR002, their secondary endpoints are ctDNA and circulating tumour cells. So they're looking to see whether those at various time points can predict for those patients that will progress quickly after treatment and predict. So they're predictive and prognostic, and those patients that are going to do well with SABR or metastasis-directed therapies. I think they're the big candidates. And I think, clearly when we practice, we treat some patients and they progress very quickly after our treatment. We treat other patients and they remain disease-free for years. So obviously being able to classify those two groups is very important. And already in the BR002 trial, there's going to be some prospective information come through on those two biomarkers.
I was also answering this particular question in the chat box. This is $1 million question. And literally, because it costs a lot to even measure circulating tumor cells at one time point, leave alone at several time points during follow-up. So my question to Dr. Kishi is that for a patient who is from a lower and middle income country, what are the other biomarkers? Is size at all a criteria? And I'm asking you specifically because in Japan, you have access to carbon ion, proton, where size is not a concern. You can treat any size, even up to 10 centimeters. So if a metastasis has grown up to 10 centimeters, would it be a concern? Would you consider this as a marker and call it a good prognosis or a good biology that the disease has not spread, or a bad biology because it's 10 centimeters? Is size at all a criteria? Dr. Kishi?
Yep.
This is a question directed to
yes,
you.
To improve the survival, we do immunotherapy, and to the triple negative cancer with PD-L1 positive, we can use the ICI, but this is not theoretically related to the triple negative. I believe any pattern of cancer can be treated with ICI to enhance their own immunity. So what's the immunity? What immunity do you know? We can see the decrease of the lymphocyte. We are observing every day the patient's lymphocyte is decreasing after so many times of radiotherapy. The lymphocyte number is come to, in some case, 200 or less than 500. The healthy person has more than 10,000, or I have 2,000 and more lymphocyte number. So the problem is immune defeat. So to overcome the immune defeat, should we use the stereotactic radiotherapy so frequently? No, we have to spare the time and keep the lymphocyte number as well as we can. So that's the key to win this game. And our next goal is to enable the use of the ICI to the all breast cancer with the difficult conditions, not only to the triple negative cancer. Yes, thank you so much.
Yep. And though that was not the original question, I think you've answered regarding what are the other important endpoints and what are the other important treatment modalities that are available to treat with SBRT. My question to Sareen sir is that when we talk about biomarkers and predictors, we've often talked about the size of the lesion as one of the predictors. And I remember a discussion where we spoke that a large size, though maybe reported in literature, might still not confer the oligometastatic potential that is originally defined. And I'm bringing this point over here is because I have a contrasting point in literature as well.
The size, why size matters, it reflects chronology, how long it has been growing, and the biology. These are the two things. And in terms of treatment, because in the larger size, it can cause more doses to the normal tissue. So if the tempo of the disease is low, and if you can give a high dose, depending on where the lesion is, then size per se is not so important. So I think you have to take it in overall context. Just because the size is bigger So the biology of disease, not all tumors, and different tumors, some tumors, even if they're 2 centimeters, they're much more hypoxic. Whether there's a glioblastoma, even if it's a tiny little one, it has a lot of hypoxia, whereas some other tumors are not so hypoxic. So there are various things you have to take into account. Size is just one of those things.
Right, we do have a contrasting analogy in one of the papers from the recent JCO publication, where they showed that if the size is smaller, like say about between 2 to 8 millimeters, it's actually a problem because there may be more occult metastases still waiting to emerge and surface in due course of time. And which is why it is important that the extremes of size be treated with caution. So we know that there are several things, and like Dr. Sareen rightly pointed, it's not just one thing. We need to take everything into account and use a multimodal predictive system in future. Now, what did our panel or our participants suggest? So in decreasing order of importance, they suggested things that they would rely on before considering patients for oligometastatic directed therapy are the number of metastases, organ, the performance status, life expectancy, local regional disease status, acceptability in terms of toxicity of the therapy, response to systemic therapy, molecular subtype, effective salvage therapies available, and reliability for follow-up as important markers before taking any clinical management decision. You can see over here, I've just displayed one of the nomograms, which is a metabank nomogram, but it is one of those that are trying to pull in all of this together like a recursive partitioning analysis that helps us define our patients better or prognosticate our patients better. Now, there are certain contraindications that have just been pointed out, which are obvious, that the disease that are diffuse, like pleural effusion, leptomeningeal involvement, peritoneal carcinomatosis, are not going to be considered as oligometastatic. Coming to classification, now, both Dr. Guckenberger, Dr. David, and Dr. Shupal have spoken to us about different classifications. And though it is extremely confusing at this point in time, there are these 5 questions that need to be asked, and these disease entities need to be classified. Do you use, so coming to the panel, where do you see this classification system? Do you think that this is prime time? We will be using it in our clinics? And I would start with Shalaka. Do you think tomorrow you're going to start classifying patients with this particular system?
So Rima, you can go back to the previous table to make me understand the new classification better. But what I think we routinely classify oligometastatic disease as somebody who presents upfront with oligometastatic disease versus somebody who's been on follow-up and comes to you as an oligo recurrence and you want to treat it with an aggressive intent. And thirdly, but maybe more controversial, is the area where somebody's got multiple metastases to begin with and has at the end of primary systemic therapy is left with very little residual disease as oligoresidual disease. So in my head, this is how you classify oligometastatic disease, the scenarios that you see in the clinic. But this new classification system, I'm not sure if we are using this routinely in the clinic.
Dr. David, do you use this in your clinic?
Yeah.
Are you starting?
Yes. I think a couple of comments. One, I just want to say, where possible, we always try to enroll someone on a clinical trial. And I think that's an area we don't do enough of, or even a registry. That's one point. And the second point is, we have one trial in breast cancer called Avatar, which looks specifically at oligoprogression. And we do try to think about it, and it's oligoprogression in ER positive disease. And where possible, I think most places, and where you can't have clinical trials due to expense, you should have registries, prospective registries. So at least we're trying to build the body of evidence around that. And I think we certainly think about it, and we try and enroll patients on trials.
So coming on to case discussion, I'll probably just discuss 2 cases and quick answers. So this is a 38-year-old female with a T3N2 disease and 2 sites of liver metastasis. How do you manage 2 sites of liver metastasis in your practice, Dr. Geeta? Would you consider this patient, both of them are in right side of the lobe of liver, would you treat this patient with metastasectomy? Would you treat this patient with chemotherapy, wait for response, if vanishes, then call it a day? Or would you send this patient to a radiation oncologist for treatment?
So in this case, I would, start off with systemic treatment and of course place a clip in those 2 liver mets that you're seeing. And then possibly, then we would, yeah.
Okay. Anyone else who has a conflicting response to this? Would anyone directly go in for SBRT treatments?
Rima, I agree with the point made by Geeta, but in addition, I think every patient with liver metastasis, even if it is oligo on PET scan, should have a triple phase MRI of the liver.
So we've confirmed triple phase MRI shows these 2 sites as the only site of disease. Would you now start this patient on systemic therapy?
Yeah, systemic therapy with a clip marker placement.
Right. And after you finish your systemic therapy, if you can't see any disease, what would you do about these 2 lesions? Would you still target the area, or would you consider them as those who have brilliant response with chemotherapy and treat only at progression?
See, we can.
Yes, Dr. Nandya.
No, go ahead, please, Vinita. Please go ahead.
Ma'am, please go ahead.
No, what I meant to say was that we don't necessarily have to wait for the entire chemo to be over. And I would be quite happy actually after a couple of cycles to offer SBRT to the patient.
And in your practice, have you seen any greater toxicity when you combine it in between cycles, like a sandwich therapy?
No.
Neither have we. So we've also treated most of these visceral metastases in between chemotherapy cycles. And so far, we've been lucky to not have any serious toxicities. I'm being signaled by my co-organizers that we've been losing time. And just one other point that I needed to make was that in a patient, so this patient record again, and we treated again with SBRT, and patient unfortunately referred for the 3rd time. So this is a patient where you have induced oligometastasis or oligometastatic disease. And they also sometimes do better. But coming to another case scenario, which is often seen, and this is very important for a person who's treating synchronous metastasis, is that when you have a case like this, here you can see that the D2 body has metastatic lesion, where you also have to treat the supraclavicular fossa for locoregional therapy. How do you combine these 2 treatments? Dr. Sapna, you have it easy because you have proton, where you can limit doses to both these sites, give different doses. But for the lesser mortals like us who treat with photon, I would like an answer from Dr. David on this, and then Dr. Mohsin.
I would just like to clarify that I too treat with photons. I treat with photons too. Sorry.
Yes, I've had a case exactly like that, and we planned both the SABRE and the breast nodal radiotherapy at the same time, and sculpted the SCF dose around the vertebral body, and then waited a little bit of time between the end of the breast radiotherapy and the treatment of the metastasis. But what we did was we made sure that the organs at risk, in particular esophagus, trachea, and spinal cord and brachial plexus, were kept within tolerances, and we've made sure that the extra dose, because there was some from overlap, was focused on the GTV of the metastasis.
So would you like to treat this patient with 1 or 2 fractions or 5 fractions of radiation and maybe 15 fractions of radiation to the supraclav, or you would like to conventionally fractionate?
No, we would treat 15. We did 15 fractions to the supraclav and breast, and then 3 fractions to the vertebral metastasis subsequently, but we planned it all up front at the same time, and we waited a couple of months between the end of the breast and we re-imaged the patient between times with a PET scan to make sure there was no widespread progression. But the organs at risk were kept in mind, the main ones being, as I said, trachea, esophagus, cord, and brachial plexus.
Any other radiation oncologist would want to weigh on this?
Rima, I would have treated this patient with a combined plan, maybe a 15 fraction plan combining both supraclavicular fossa and vertebra together. A single plan.
In our practice, when it's so close by, we would also treat with a combined plan and with 15 fractions rather than treat with 3 fractions. So again, my organizers are saying that we are really running short of time, and I would end my panel at this. We have lots to share, lots to talk about, and I think the future is in collaboration. So I would really urge every one of you who maintains oligometastatic patient registry, or for that matter, a log, we should try and combine our databases to try and come together, answer these questions from an Indian perspective, from an Asian perspective, and come up with data that is convincing enough to practice further for all other patients. Thank you so much. And with that, I would now invite my next organizer, Dr. Jyoti Bajpai. Is Dr. Sudeep here? Is sir here?
Yeah, I'm here. I'm here.
Sir, then I would like you to please give your valuable 2 cents that you've given on chat box here. Please go ahead.
Okay, can you hear me?
Yes, sir.
So good afternoon, everyone. We had a truly fascinating session which dealt with an issue on which there continues to be equipoise and uncertainty. And if some of you have read my comments in the chat box, then you would know that I'm not yet completely convinced about the need for local treatment in oligometastatic disease, especially in breast cancer. I would like to make the point that our ability to image and deliver local treatments with sophisticated techniques should not be confused with the need to do so, especially when some of those techniques are either complicated or toxic or expensive or all of them. The main reason, as you would have noticed, is the lack of robust actionable evidence with respect to local treatment. The few randomized trials that have been reported have small numbers and are hopelessly underpowered for reasonable conclusions. It is heartening to note that some ongoing trials that were depicted today have much better power and will hopefully answer the question of local treatment in oligometastatic disease more definitively. Mm-hmm. As one of my colleagues mentioned during the panel discussion, at least as far as I'm concerned, overall survival would be the yardstick by which I will measure success. Progression-free survival is longitudinal, millimeter by millimeter measurement of the tumor burden and does not connote patient benefit by itself, especially in metastatic settings. And when those larger trials are done and dusted, it may well turn out that local treatments do benefit patients. But as all of us have been taught, until then, we must also be cognizant of the possibility of the null hypothesis not being rejected. Having said all of this, the data and the talks that were presented today were absolutely wonderful. And like all of you, I learned a lot. I congratulate all the faculty members who were involved in this session. The most striking thing from this session for me was the need to collaborate and pool our patients in the cause of generating high quality evidence in this uncommon but important clinical scenario. My best wishes, and I hope all of you enjoy the rest of the meeting. Thank you very much.